Good morning, everyone.
Good morning.
Good morning. My name is Dr. Curtis Williams. I'm the staff chaplain here at the Atlanta VA healthcare system, and I'd like to welcome you to our Whole Health First Fridays event. I have been facilitating the mindfulness classes in our Whole Health First Fridays program, and I want you to know that it's a sheer delight as we explore together monthly on a theme that builds on whole health and allows us the freedom to become aware of what's happening within us and around us. And they serve as tools for our enlightenment and empowerment. When I worked at as a whole health coach with the Empower Veterans program at the Atlanta clinic, we helped veterans to see themselves literally at the center of their care in order to move them from the previous model of problem-based disease care to our new approach, which is focused in on whole health. We help them to see themselves not as a collection of diseases or a problem on a list. Oh no, but as whole persons, living life fully as whole persons. And that's really what mindfulness is all about. Mindfulness builds our capacity to notice, to sense both the external as well as the internal environment in the present. Mindfulness is a way of learning to pay attention to whatever is happening in your life. And it gives you or allows you a greater sense of connection to your life inwardly and outwardly. Mindfulness is also a practice, a systematic method that's aimed at cultivating clarity, cultivating insight, cultivating understanding. In the context of our health, mindfulness is a way to experientially learn to better take care of ourselves by exploring and understanding the interplay of mind and body, and then mobilizing our own resources to assist us with coping and growing and healing. So mindfulness really is a way of learning to relate directly to whatever is happening in my life, a way of taking charge of my life, a way of consciously and systematically working on my own stress, dealing with my own pain, my own illnesses, and the challenges and demands of everyday life. You see, when I discovered this skill, it became so empowering. And mind you, I've served as a pastor for 20 years, and I had the ultimate power source at my disposal, if you will. But this technique that comes out of, if you will, the theological flow, helped me to get involved and to take time to just notice and observe me in the context of my own experience, my mind, my body, my environment. And so in today's observer self-practice that we'll engage in, it provides us an opportunity to step out on autopilot and practice observing our experiences. So we're going to jump right in just a moment with this observer self-practice of mindful awareness. We'll begin to explore or notice our thoughts, our feelings, our sensations without getting caught up or trying to change the experience. Just observation. Now, this practice will also include a comparison of mindful awareness akin to or being like the sky. Remember that. And our experiences, like thoughts, sensations, and feelings, they're like the weather, changing. But the sky, ever present and stable. We know the weather constantly changes throughout the day, and as we can see today, and we can observe the weather, but in mindful awareness, we observe it without getting caught up in it or trying to change it. And our awareness, the sky, can simply contain it all. So for the next 20 minutes, I invite you in to your own world, to have the opportunity to experience and practice mindful awareness. Every time we notice that our mind has wandered, that is successful, because we are simply noticing the wandering mind, and we have an opportunity again to be present right here and right now. So if you haven't done a mindfulness exercise before, I invite you to treat it as a kind of an experiment, looking through a microscope and observing what's going on with you. Don't alter it. Don't change it. Just sit with it and let it be. So let's get started. Switch off your cell phones, put them on vibrate, and set them down. It helps to have our hands free. We'll be doing this, as I mentioned, for the next right at 20 minutes. As we begin this observer self mindfulness exercise, I invite you to find a position in which you feel supported and alert. Just allow your body to settle into your position. You may choose to rest your gaze downward on a spot in front of you, or if you prefer, you can gently close your eyes. And as we are learning to let our minds settle, bring your attention to your breath. There's no need to do anything different with your breath. Just simply observe the breath as it is breathing itself. See if you can rest your attention on the tip of your nose, right where the air first enters your body. Notice that place where air becomes breath. Notice if it has a temperature, maybe a texture. And now, follow the breath as it comes in through your nostrils, and follow it as far as you can down through your body. Until you can no longer notice the difference between your breath and the rest of your body. See where that spot is, where the breath simply becomes the rest of your body. And then follow the breath back out again. Notice that spot in your nostrils where the breath finally leaves your body and becomes air again. Notice if that spot has any temperature or weight. And continue to follow your breath as if you're riding waves of breathing. Notice the air moving in and out of your nostrils. You may notice that it's slightly cooler as it comes in and warmer as it goes out. Notice the gentle rise and fall of your chest. Notice the gentle rise and fall of your belly. And while you're noticing this, you might also notice that your mind has wandered off. Minds do that. Simply becoming aware of it, noticing that your mind has gotten hooked by thoughts, allows you to gently bring your attention back to your breath. You can fix your attention on the breath, either moving in and out through your nostrils, or the rising and falling of your chest or belly, whichever you prefer. Just keep your attention on the spot, noticing the movement in and out of your breath. And whatever feelings, urges, or sensations arise, whether they're pleasant or unpleasant, just simply acknowledge them as if you were nodding to people passing by on the street. Gently acknowledge their presence and let them be there. Allow these feelings, urges, and sensations to come and go while you keep your attention on the breath. Whatever thoughts, images, or memories arise, whether they're comfortable or uncomfortable, simply acknowledge them and allow them to be. Let them come and go and keep your attention on the breath. And from time to time, you'll notice your attention getting distracted by thoughts and feelings. Each time you see this happening, simply notice what distracted you and then bring your attention back to the breath. There's no need to be disappointed or impatient when you're carried off by your thoughts. It's the same for everyone. Our minds tend to distract us from what we are doing. And each time you realize your attention has wandered, just gently acknowledge it. Notice what distracted you, and then return your attention to the breath. If frustration, boredom, anxiety, impatience, or other feelings arise, just simply acknowledge them and then gently bring your focus back to your breath. No matter how often our attention wanders, just simply, gently acknowledge it. Know what distracted you, and then gently bring your attention back to your breath. Be curious about this sensation of breathing that is occurring. And next, see if you can become aware of the thoughts that are occurring. Where do they seem to be located? Are they moving? Or are these thoughts still? Are these thoughts pictures or words? Just notice whatever thoughts are occurring in your mind. And as you notice your thoughts, simply become aware that you're noticing. There are the thoughts that are occurring within you, and then there is you there noticing your thoughts. If you can notice your thoughts, you cannot be your thoughts. And your thoughts change continually. Sometimes they seem true, sometimes false, sometimes positive or negative. Sometimes thoughts occur to you that make you feel happy or sad. But the part of you that notices your thoughts does not change. And when you were a child, your thoughts were very different than they are today. But the you who could notice your thoughts as a child is the same you who can notice them now. And if throughout this exercise you notice yourself getting caught up in your thoughts, that's okay. It's very normal. As you notice that, see if you can simply observe those thoughts. Just letting them come and go like passing cars. And I invite you to continue in this exercise no matter how hard your mind tries to pull away. And now, notice your body. Notice how you are sitting in the chair. And as you do that, be aware that you are noticing. There is your body, and there you are, noticing it. It's not the same body you had as a baby, or a child, or a teenager. You may have had bits put into it or bits removed. You have scars and wrinkles. It's not the same skin that you had in your youth. And the part of you that can notice your body never changes. As a child, when you looked in the mirror, your reflection was very different than it is today. But the you who could notice your reflection then is the same you who can notice your reflection today. And now, scan your body from head to toe and notice the different feelings and sensations. Pick any feeling or sensation that captures your interest and observe it with curiosity. Notice where that feeling or sensation starts and stops. Notice how deep in it goes, what shape it is. See if that feeling or sensation has a temperature. What about a texture? And as you notice this feeling or sensation, just be aware that you are noticing. There's the feeling that is occurring within you, and then there is you there noticing it. If you can notice this feeling or sensation, you can't be this feeling or sensation. Your feelings and sensations change continually. Sometimes you feel happy or sad, stressed or relaxed. But the part of you that notices your feelings does not change. And in your life today, when you're frightened, angry, sad, anxious, the you who can notice those feelings now is the same you who could notice those feelings as a child. And next, notice the role you are playing in this moment. And as you do, be aware that you are noticing. Right now, you might be playing the role of a member of this group, but your role changes continually. At times, you are in the role of a mother or father, son or daughter, brother or sister, friend or enemy, student, teacher. And if you could notice those roles, you can't be those roles. And those roles change. There are some roles that you will never have again, like the role of a young child. But the you who notices your roles does not change. It's the same you who could notice your roles even when you were very young. This part of you that can observe your roles, that can observe your thoughts and feelings and sensations and breath, we call that part the observer self. And the observer's self is like the sky. Your thoughts, sensations, and feelings, they're like the weather. The weather constantly changes throughout the day, and whatever it is, the sky always has room for it. No matter how bad the weather, no matter how violent the thunderstorms, no matter how severe the sun, the sky cannot be damaged in it in any way. Even hurricanes and tsunamis, which may bring destruction on land, even they are unable to hurt the sky. The sky can simply contain the weather. And of course, as time passes, the weather will change again and again, while the sky remains as pure and clear as ever. And so now, as we draw near to the end of this exercise together, from this place of connecting with that observer self, see if you once again can notice your breath. Notice your body, how you are sitting. You might picture in your mind's eye what you will see when you refocus your gaze or open your eyes. And whenever you're ready, gently refocus or open your eyes and look around. Thank you for participating in this self-observer mindfulness practice. I hope that what you see is what is your reality, because the sky always has room for it. Whatever changes are that occur in your life, remember, the awareness proposition is sufficient, and you will be able to contain all of the issues of life by becoming aware. Blessings upon you all. Have a wonderful afternoon. And good morning to you, by the way.
I want to tell you a little bit about Dr. Shatil. Dr. Shatil grew up in Connecticut, and she went to Rochester, New York for her undergraduate work. And then she writes that she briefly escaped the cold by working in Israel for a year before returning to Marquette University in Wisconsin. Wow, back to the cold, for sure. And then she completed her PhD in clinical psychology at Marquette and actually began working at the Atlanta VA as an intern, doing her internship in about 2011, and then went on to do her residency here in psychology in 2012-13. And she joined as a psychologist for the sleep medicine clinic in 2013. And since late 2015, she's also been a part of the whole health team, which we have been very blessed to have her as part of our team. And if you don't know what she does for the team, it's a lot. So at the Arcadia Clinic, she is the mindfulness coach and instructor, and so she does our 8-week mindfulness meditation class at the Arcadia Clinic. She also teaches a class monthly on, well, twice a month actually, or on stress reduction. So she's a very important member of the team. She's been with us since 2015, so that is really at the very, very beginning of all of this, and so we appreciate her. She serves on the core postdoctoral training committee and extended internship training committee. She's an active member of the diversity education committee for psychology training and the hospital-wide whole health life committee. She coordinates the health psychology seminar series for psychology postdoctoral residency and supervises residents and interns in group and individual psychotherapy. She also spends time as a training consultant for the National VA evidence-based practice rollout of individual and group CBTI, cognitive behavioral therapy for insomnia. And if you don't have that app on your phone, you need to have it. She may address that during the talk. Her professional interests other than health psychology include mindfulness, multiculturalism, trauma, and supervision and training. And so we are very, very glad to have her today. And she is, talk about being in the middle of a busy clinic day and still finding time to do this. When she emailed me this morning, she said, "Oh, I'll be right over from Arcadia. I just have 2 patients this morning." And so I thought, oof, she's going to be late. But she got here on time, and she also has a patient right after this, as well as I think a meeting at noon. And then her daughter's in a play. So she has fit us in the middle of a very busy day, and so we really appreciate that, Dr. Shatil. And I was logged on earlier, so I'm counting on this to just take but a few minutes to come up, because usually it should recognize me. Yeah, and then it's right where you put it. Yeah.
Okay, good.
So
I can find it.
You can find it.
Yeah,
Okay, great.
thank you.
All right, awesome.
Thank you all. So thank you for being here. And today we're going to be talking about sleep. So today we're going to talk about recognizing normal and abnormal sleep and what you can do about it. So I want to acknowledge my peers who have helped me out with this presentation. So some of these slides have come from a group of VA CBTI training consultants that's through the VA central office. Some of these slides have also come from Dr. Barry Fields, who is one of the sleep medicine physicians. And one of the slides also came from Candace McCarver, a PA who used to work at the VA here and was also one of the original members of the Whole Health for Life Clinic before it was even called that. So I'm going to leave time for questions at the end, but please feel free to kind of in the middle, if you aren't sure of something that I'm saying or you're not quite sure of a slide. I have on here, my high school biology teacher used to say, just kind of go, word ignorance, but you don't really have to say that. Just kind of feel free to jump in and say, oh, what is that? So, normal sleep. We all hear, how much sleep do we need? 7 to 8. Everyone says 7 to 8 hours, 7 to 8 hours, right? Normal sleep really is within the realm typically of 6 to 9 hours, and it's individual needs, right? People need individual amounts, and there are even some people who really only need 4 or 5 hours. We call them short sleepers, and they're okay. They don't have any health problems, they're fine, but that's what their bodies need. There are some people who really can't get by without 10 hours, and we call them long sleepers, right? Much below 4 or 5 or above 10, typically there start to be some problems, right? So we have 4 stages of sleep. What's the one that everybody's heard of? Everyone's heard of REM, right? Yeah, we've all heard of that vivid dreaming stage of sleep. It's the other ones that are a little bit, huh? And we used to have 5 stages of sleep. They combined N3 and N4 and just made it one. They realized they weren't really that different. So N1 is super, super, super light sleep. That's where you think you're almost still awake. When you're dozing off on the couch, somebody says, hey, wake up. You're like, I wasn't asleep, right? N2 is slightly deeper. You can still pretty easily be woken up. N3 is that really deep sleep. Slow, your brain goes into nice slow waves. And then REM, like we said, is vivid dreaming. N is really fancy. N stands for non-REM. So it's 3 not REM stages of sleep and 1 REM stage, okay? And you can see these are kind of hypnograms for, which is a fancy word for pictures of the different stages that you're in throughout the night, right? And you can see for a younger person and an older person. And a younger person, we're thinking of like 20s, 30s, and an older person like late 60s, 70s, and above, right? So you can see we go through cycles of N1 through REM throughout the night. These cycles tend to be about 90 minutes, plus or minus about 30 minutes. And so some people will say, oh, I wake up every hour, or I wake up every 90 minutes. And depending on how old they are and depending on other things, we might say that's actually completely normal, right? We tend to wake up at the end of one of these cycles. But it's the ability to just fall back to sleep pretty quickly that's important, right? We get more, and it's easier to see in this younger person picture than the older person picture, but we get a lot more of the deep sleep towards the beginning of the night and a lot more of the REM sleep toward the end of the night. We get all of the stages in each cycle, usually, although we might not get the deep sleep as we get to the end, but we get more, they're kind of distributed differently, right? If we're looking at how sleep changes as we age, now remember, this is all normal sleep so far, right? So as we age, we tend to get less of that deep sleep, less of that stage N3. And that REM kind of stays consistent, everything else stays consistent. Everyone hears, oh, you need a lot less sleep as you get older, right? It's not really true. Maybe a half hour less, not much, right? So we still need sleep even as we age. Sometimes people will spend more time awake in bed as they get older, which we'll see is not super helpful. So how is our sleep controlled? How does our body know when it should sleep and when it shouldn't sleep? So this is what we call the 2-process model of sleep. And we'll see there's 2 main ways that our body controls our sleep and 1 way that our mind controls our sleep. We know that's a little bit false to kind of talk about it that way, right? Because our mind and our body are so closely connected. They're kind of the same, but it's easier to think about it this way. So we all have something called a sleep load or a sleep drive. So your sleep drive is very similar to your hunger drive. So what happens if you wake up in the morning and you don't eat for a really long time? Your body starts telling you, I'm hungry, feed me, right? And the same thing goes with sleep. If you don't sleep for a very long time, eventually your body goes, I need sleep, right? And some people who don't get good sleep will go days with really poor sleep, and then suddenly they'll crash. They'll get like 1 decent night of sleep. And that tells us that their sleep drive is perfectly fine, right? Your sleep drive is really just a chemical that builds up in your brain. It's called adenosine. It builds up and tells your brain, hey, you're sleepy, right? You need sleep. There's something that we might drink that kind of sits in those same receptors and tells your brain, no, you're not sleepy. What might that be? Coffee. Yeah, exactly. So sometimes we might be drinking coffee and that will tell your brain, nope, you're not actually sleepy. But that chemical is still building up. It's just sitting in those same receptors. So it's blocking your brain from knowing that it's sleepy until the caffeine wears off, right? So if we didn't have that bottom piece, if I were able to kind of cover up that bottom piece of this picture, we would really all wake up and do a bunch of daily activities, and then we'd take a nap, and then we'd wake up and do more daily activities, and then we'd take a nap, and we wouldn't have any set 24-hour cycle. So what helps to give us a 24-hour cycle is our circadian clock, or our circadian alerting signal. Has anyone ever heard of that before? Okay, yeah. So circadian is a fancy word, because we like making up big fancy words, right? And it just comes from the Latin circa, which means about, and diem, which means a day, right? So it's our about a day clock. Because if we were shut somewhere with zero light whatsoever, our circadian clock would on average be about 24 hours and 20 minutes. Some people less, some people more, but it wouldn't be exactly 24 hours. Light is super important to this circadian clock. So when we wake up in the morning, it's great to get lots of good, bright light. And that helps us to kind of set our clock. Later at night, why are we all told to get off of our devices late at night? Because that bright light. Yeah, exactly. So the bright light, we go, oh my gosh, right? And it wakes us up and keeps us from falling asleep. So we want things to be nice and dim at night. So what are some things that you think might get in the way of either the sleep drive, sleep load, or this circadian clock? Yeah.
Lots of things. Activity, exposure to artificial light, chemicals, your exposure to sun and moon.
Yep.
That's kind of
Yeah. So like you said, there's a ton of things that can interfere, right? So looking at this circadian clock, you were saying that light will really kind of interfere. Or activity. And activity can interfere in the circadian clock in a few ways, right? So if we're exercising close to bedtime, that raises our core body temperature. And our core body temperature kind of follows this same basic rhythm. So we're at our kind of coolest in the middle of the night when we're trying to sleep. And so that helps us to stay asleep. And if we raise our core body temperature, it makes it harder to sleep, right? So that's one thing. It also just kind of makes us more alert, right? So some people will exercise trying to build up that sleep load, and it does build up the sleep load, but it interferes in the circadian rhythm, right? So we want to exercise earlier on in the day, if possible, at least 3 hours before going to bed, right? What do you think happens if you get up at 6 a.m. one day, 4 a.m. another day, 8 a.m. another day?
throws off your rhythm.
Yeah, your body can't get into a rhythm, right? Your body doesn't know when it's supposed to actually be alert, right? And so you basically walk around feeling jet lagged, right? You see this really clearly with people who work during the week, and they get up maybe at 5 during the week, and then on the weekend they sleep in till 8, and then Monday rolls around. It's one of those reasons people hate Mondays, right? Because they've basically gone California, East Coast, and it just doesn't feel good, right? So that's why we say kind of try and keep your wake up time the same, right? So you can see we become more alert throughout the day as our sleep load is building up, and that kind of helps us to feel steady throughout the day. Other than, you probably notice, in the mid-afternoon, our alerting signal levels off for a little while, but the sleep drive is still building up. So most of us feel a little bit blah in the mid-afternoon, right? Many of us, and in many cultures, they take a nap, right? They take a siesta during that time, right? But what happens is they take that nap then, and then they wait until much later to go to bed, right? Their sleep is just broken up into 2 chunks, Whereas in our culture, we tend to get it all in one big chunk, right? So I've just basically told you interfering in the sleep drive is going to be naps, right? And people say, but I love my naps, right? And a 20-minute nap earlier on in the day is not a problem, right? And if you need to take a 20-minute safety nap to drive, by all means do. We want you being safe while you drive, right? But after you hit that half hour, especially 40 minutes, that sleep drive, that sleep load starts dropping drastically. And it becomes much harder to sleep at night, right? So, it's kind of going on. So we've talked about if there's excess time in bed will also weaken the sleep drive, right? Because you're not getting up and doing daily activities. And if you're just lying there in bed, it's not going to build up, right? Even those 20-minute naps, if it's too close to bedtime, going to be a little bit difficult, right? And then we talked about sleeping in and caffeine. The circadian clock. We talked about all of these except for the regularity of other activities, right? The more you have a schedule in general, right? The more you kind of eat your meals at the same time, are doing other things at kind of similar times, that also helps you to get on the schedule. I will say that's important. Light is the most important, and that regularity of light exposure and getting up at the same time. Yeah.
Excess time in bed, how is it, why is it?
So in a few ways. So the one that's relevant to the sleep drive and the circadian clock, it impacts the sleep drive in that you're lying there, you're not doing daily activities. So the sleep drive can't build up, right? The circadian clock, if you're lying there past when you would normally get up, it's going to shift your clock, right? You're not exposing yourself to the light, you're all that. Now, the third piece I'll jump to and then I'll come back. Oh, where did I put it? I guess, I was just going to talk about it, but didn't have it in here. So the third piece is kind of our association of bed with sleep, what we call conditioned arousal. And I do have that kind of further on when we're talking about insomnia. But conditioned arousal, if you're lying in bed awake, what does your body learn? I'm awake in bed, right? Because we learn by pairing things together. So if we're in bed watching TV, on the phone, having a serious conversation with our partners, right? Any of these other things, or just worrying, tossing and turning, being in pain, right? If these are the things that we're doing in bed, our brain learns, I lie awake in bed, right? So going back to the circadian clock, we talked about this. It's helpful just to kind of recognize that our clocks are not all on the same schedule, right? So some people, kind of normal sleep phase might be going to sleep around 11 and waking up around 7. There's some people that we might call night owls that might have a delayed sleep phase. They might really be wide awake at 11. They might do their best thinking around 11, midnight, 1, and not be able to fall asleep until 2 or so. And then when they need to get up for work in the morning, it's really, really hard to get up, right? And then around 10, 11, they're fine. Get up, go on with their normal day, right? And then we have the opposite, which are the advanced phase, which we call morning larks, right? And they have trouble staying awake around 8 or 9 p.m. They just feel super sleepy, need to go to sleep. And then they wake up at maybe 3 or 4 in the morning, right? My mom and one of her friends were having a conversation. They said, I love 3 a.m. I get my best thinking, I get best work done then. And her friend said, yeah, me too. Don't you love waking up then? My mom looked at her, waking up? That's when I stay up until, right? They're just gone completely opposite ends, right?
So are those the people you call morning people?
Right, morning people and night owls, right? Right. And so some people say, oh, I'm a morning person. I do my best work at 7 or 8 a.m. And I'm like, that's actually pretty normal. A morning person, we're thinking of somebody who's up and ready to go at 4 or 5 a.m. You know, so who do you think we tend to see more in clinic as having more problems? Your night owls, exactly. Because society says you need to be up and working at those times that a night owl would like to be sleeping, right? And they don't care if they don't go out with their friends at 8 or 9 p.m., right? But none of this is a problem unless it's a problem, right? So plenty of people who are night owls can work second shift very well. And then we wouldn't call it a problem because it fits with their life fine, as long as it's also not interfering with their social relationships or anything else, right? So what we want to say is that a strong sleep drive plus sleeping at the right time for your body plus having low arousal, not in here, plus not having physical sleep problems, right, is going to lead to good sleep. So that's good in normal sleep. Then there's the not so normal sleep, right? So this is kind of sleep disorders in the general population and the VA. So insomnia is something that is chronic, right? So insomnia means that it's taking you at least 30 minutes to fall asleep, or you're up in the middle of the night for at least 30 minutes, or you're waking up at least 30 minutes early before you intend to, at least 3 nights a week for at least 3 months. Do not ask me where we got all these 3s and 30s. But that's just sort of what they've determined. And there can't be a better explanation for it, right? And it has to be causing problems again. So in the general population, insomnia tends to be between 9 and 15%. In the veteran population, it tends to be between 40 and 53%. So, and you can all guess why, right? So for obstructive sleep apnea, in the general population, and obstructive sleep apnea is where you stop breathing in your sleep. And there's good treatments for that, and we're going to talk more about that as we go on. So in the general population, it's between 4 and 12%. In the VA population, between 30 and 50% about. So, a lot more in the veteran population. Restless leg syndrome, where, especially at night, you can't stop moving your legs, you need to get up, walk around to get your legs to calm down. In the general population, 5 to 13%, veteran population, 13 to 20%. Narcolepsy, that's that sudden, you might hear sleep attacks, the seeing and hearing strange things as you fall asleep and wake up, and there's lots of other things associated with narcolepsy, but that's 0.2% in the general population, 5 to 13% in the veteran population. And then parasomnias, which there's a whole host of those, anything from nightmare disorder to sleep eating or, things like that, right? Yes.
I think I got that because it's like I'll eat a meal, and then around about 2 or 3 o'clock in the morning, I'm hungry, and I wake up out of my sleep. I go eat something.
So that is something totally different, actually. Yeah. But it is a sleep, can be a sleep problem, but it's not a parasomnia because you're eating while you're awake, right? You're waking up to eat. You're feeling super hungry, and that is, I believe, called night eating disorder. So it's like where you wake up, eat, but you're awake when you eat, right? Yeah. Some people will get up fully in their sleep, they're sleepwalking, and actually eating in their sleep. Yeah, they don't know that, like, they'll wake up in the morning and find crumbs and not have any idea of how they got there. Yeah. Yeah. And then there's the circadian rhythm sleep-wake disorders, which is that misalignment of the sleep period with when their body wants to be sleeping. And we talked about a little bit the delayed sleep phase and advanced sleep phase, but there's also non-24-hour type and shift work disorder. So there's other types, and they have some okay estimations for how much in some of these types, but not overall. So that's why I have a question mark there. It's not a really good estimation. So this is sort of the decision tree of sleep problems, right? So with sleep, we can have problems with quality and we can have problems with quantity, right? So if there's a quality problem, it is usually related to sleep apnea or a parasomnia or restless leg syndrome. If it's a quantity problem, not getting enough, if it's too much sleep, which some people say, how can you get too much sleep? But somebody who gets too much sleep and really is always feeling sleepy will tell you, you can need too much sleep, right? You want to be able to function during your day and not just feel sleepy all the time. Yeah?
Can too much sleep also be related to depression?
Yes. So so these can also be related. So too much or too little sleep can also be related to depression. It can go both ways, right? But if it's purely related to sleep problems, then it can be, the increased quantity can be related to narcolepsy or what we call idiopathic hypersomnia, which is just feeling overly sleepy, right? And if there's too little sleep, that's usually related to that circadian rhythm problem, not having your sleep lined up right, insomnia, and just poor sleep hygiene, not doing what you need to do in order to get good sleep, right? So we today, because you can see there's a lot under the umbrella of just sleep, right? We're going to focus mostly on insomnia and sleep apnea, and if we have time, we can touch on some of the other stuff. So, insomnia. I don't know if that looks familiar to anybody, but... So, we talked about what it is a little bit, but it occurs, this is important, despite adequate opportunity and circumstances for sleep. Because there are many people who think that they have insomnia, but it's that they actually have not given themselves enough time to sleep. A lot of times in our society, we don't give ourselves enough time to sleep, right? We have so much going on that we're like, no, I have to get this and this and this and this done. And by the time you get it all done, you're not giving yourself enough time to sleep. And then, or you're kind of jumping straight in from your day into trying to sleep. And you haven't given yourself any time to wind down in between getting stuff done and trying to sleep. So, and it needs to be associated with daytime impairment and distress. So with all psychological disorders, right, it's not a problem unless it's a problem. Right? We don't call it a problem unless it's causing a problem in your life. There are plenty of people that wake up for an hour in the middle of the night and they just use that time to read or whatever else, and it doesn't bother them. And they they still get enough sleep altogether, and they get up and they're okay, right? Then it's not a problem, right? Then it's not insomnia because it's not causing them a problem in their life. But if it is causing a problem in life, right, insomnia is often present at the same time as other psychiatric disorders, right? So within the VA, we often see it with depression, PTSD, other anxiety disorders, having another mental health diagnosis does not stop you from being diagnosed with insomnia. Insomnia can be a symptom of another problem, or it can be its separate other own problem, right? It's a symptom of the problem if, as you're treating this other problem, the insomnia gets better, right? Then it was a symptom, right? It's its own thing. It's insomnia disorder if it doesn't resolve after you're treating whatever else is going on. And in fact, with things like PTSD, when you treat PTSD, lots of things get much better. Insomnia tends to be one of the few things that doesn't get that much better a lot of the time. It might improve somewhat, but sometimes that's one of those things that just kind of hangs on. So having insomnia, right? So it's associated with a lot of physical, thinking, emotional difficulties. And it kind of, if you have insomnia without depression, it can actually kind of put you at higher risk for developing depression. And when it is present with depression, it is associated with a poorer response to the depression treatment. So often we will treat depression and insomnia at the same time. And that kind of helps, right? Disrupted sleep has been shown to reduce productivity, to increase healthcare costs, and also increase risk of a lot of medical and psychiatric disorders. And it's associated with other medical conditions like hypertension and obesity and type 2 diabetes, right? What I will say is people who have insomnia often are very, very concerned about their health. And that concern actually tends to make the sleep worse. So it's kind of that double-edged, right? The problems that happen with poor sleep actually tend to be worse for people who are sleep deprived versus people who have insomnia. Yeah?
So do you see a difference in sleep problems between women and men?
Yeah, so women are at higher risk for insomnia than men. Yeah, for sure. And kind of going back to that difference between sleep deprivation versus insomnia, right, which we touched on before. But when you're sleep deprived, when you're just not allowing yourself to get enough sleep, that puts you at a higher risk for a lot of problems than insomnia itself does. So if you are able to sleep, let yourself get sleep, right? Sleep is really important. So as you saw before, right, good sleep requires a high sleep drive and the right placement of the sleep period with the circadian rhythm alerting signal, right? So in insomnia, some of the factors we talked about before that interfere in sleep drive and circadian rhythm are usually present. But also, there's this increased physical arousal in insomnia. So there's a higher metabolic rate in people with insomnia a lot of times. There's higher, you might have heard of your sympathetic and parasympathetic nervous systems. So sympathetic is your fight or flight nervous system. Parasympathetic is your rest and digest nervous system. So with the sympathetic in insomnia, a lot of times that fight or flight nervous system is more like on, right? As well as your HPA axis, which is like your stress system. That tends to be more activated when you have insomnia. So
All of that right there,
yeah.
it just hit me as a woman, it just says menopause.
So insomnia often hits during menopause. Yeah. And you often have other things that might contribute, like hot flashes don't exactly make it easy to sleep. Right. You can always put on more blankets. So also, when your brain is more active, right? So you get this pre-sleep anticipatory anxiety, like, oh my gosh, tonight's going to be another bad night. Am I going to be able to sleep tonight? I don't know. You know, what's going to happen tonight? Or you start just hating going to bed. Like, I don't want to deal with that, right? Or you might get intrusive thoughts in bed, and that might be about sleep or about worries about the effects of your sleep, or it might be about things that have happened in your past or other things that might be going on, right? We might catastrophize. You might have heard of that, making mountains out of molehills, right? Jumping to the worst possible conclusion. So we might think about the potential negative consequences of poor sleep, right? Oh, I'm gonna get fired from work, or I'm going to, get into an accident because I'm gonna fall asleep driving, right? Things like that, that if you're thinking that, how relaxed are you feeling while you're having those thoughts? Not very, right? And so it's hard to sleep. And then there's also the rigid sleep-related rules. Some people will have, I have to do this, and this in order to be able to sleep. And if they don't do that, they feel like they're not going to be able to sleep. And then what happens when they aren't able to do it? Of course, they're not going to be able to sleep because they're focused on those rules. Some people say, I can only sleep if I get into bed between this time and this time. And they have that kind of stuck there. And then that, again, makes it really hard to fall asleep. So, what is cognitive behavioral therapy for insomnia? So it's going to work on these thoughts and the behaviors that interfere in sleep. So it targets all of the factors that keep insomnia going. And it's kind of comes from the science of that sleep-wake regulation, working on the things that interfere in the sleep drive, the circadian rhythm, and the arousal. And it's really pretty brief. It's about 6 sessions plus or minus 2 usually. And both individual and group formats are quite effective. So CBTI is actually recommended by the American Academy of Sleep Medicine, a bunch of physicians, right, prior to any medication, because it works, it's more effective, and we'll see this. So this is what I meant to have before. So sleep effort, sleep rules, all of that goes into what we call sleep effort. And the more sleep effort we have, the harder it is to sleep. So looking at CBTI compared to zolpidem is Ambien, right? So if we're looking at how long it's taking people to sleep after treatment, looking at the blue is they labeled it wrong. It's labeled wrong. But the blue is pre-treatment, and the green is no. That's right. No, go back. So the blue is the wake after sleep onset time. That's that being up in the middle of the night, and the green is the sleep onset latency. That's how long it takes you to fall asleep. So after treatment with CBTI, that can't be right. Let's just look at the, wait, hold on. Oh no. I know what this is. It's gonna bother me now.
Yeah.
Won't be able to get no sleep.
I know, right? Let's see if I can see what it was here. Well, let me do it if I do that. So sleep efficiency, thank you. Okay, I was like, that is not right. All right, so sleep efficiency. Sleep efficiency is the amount of time that you're sleeping out of the amount of time that you're in bed. So you want a high sleep efficiency and you want a low sleep onset latency, right? Makes so much more sense now, doesn't it? So with CBTI, The sleep onset latency, you can see, is lower than with the Ambien or with placebo, right, sugar pill. And the sleep efficiency is higher. And the combination is about the same as with CBTI, right? So then if we're looking at, this is a comparison over time. So at baseline versus at post-treatment, 3 months, 12 months, and 24 months follow-up, looking at CBTI, temazepam, which is a benzodiazepine, and sometimes given for sleep, although people have been getting away from that for lots of reasons, combined, and then placebo. So CBTI, right, all of them work post-treatment, right? They work when you're using them. But then if you stop using the temazepam, it stops working, right? When you stop taking a medication, it stops working. But when you stop doing CBTI, you've already learned the skills, and you can keep using those skills. And so the sleep stays better over time. Right? What's very interesting to me, and I love seeing this every time I finish with a patient, is I look at here it's the BDI, which is a depression scale. We use the PHQ-9 here, which is another depression scale. But so often, we've been doing treatment for sleep, but the depression score goes down, right? Because when you're getting better sleep, you just feel better, right? So the ISI is the Insomnia Severity Index score. So of course you expect that to go down over treatment.
Can you go back
Yeah.
to the slide before this again?
Yeah.
So that's really interesting because, like, the combination group, the group that got the medication and the CBTI, they actually, after treatment is stopped, don't do as well as the group that got the CBT. Almost like the medication has some sort of a negative effect on the effect of the cognitive behavioral therapy or something.
So why do you think that might be? And I don't know if it's statistically significant or not, actually, but I could see that it might be. And why do you think that might be?
Maybe they're relying more on the medication. They're just not really getting into the cognitive behavioral therapy.
Yeah, there's still like, well, the cognitive behavior, it helped, but it was only because I was on the medication too,
And then
right?
that's really cool because that's like how it's so much, because we give pills first, a lot of times other things that we know would work, people don't give them a chance.
Yeah.
That's really cool.
It's easier to take the pill opposed to doing the work.
Right.
And even if you are doing the work, right, you're still giving the credit to the pill.
Right.
Right?
Let me ask you a question.
Yeah.
CBI, I don't know how to phrase this question quite, but do you use sound frequency as part of the therapy too? Because if you listen to sound at certain megahertz, get certain results. And I can't remember the numbers. I think it's like 741 megahertz. You can get a certain level of sleep. Because I listen to different videos that have sound. Some of them are like a low hum. It's not really music. Some of them have it infused into music. But there's a certain sound that I can listen to that I'm guaranteed I'm going to be asleep before I even think about listening to the sound.
So some people fall asleep in long car rides with the or on planes, right? We don't use it specifically looking at different hertz, but we do relaxation work as part of CBTI. And so that can be incorporated into the relaxation work. And we encourage people to find what helps them to relax the best, right? We can give strategies that we know work in general, but everybody knows their own bodies and themselves the best. And so figuring out what helps you to relax. And if listening to those frequencies helps you to relax, by all means, listen to those frequencies, right? So this is sort of how insomnia develops. So we've sort of touched on some of this a little bit, but before anyone even has insomnia, this is called the 3P model of insomnia because the person who developed it, Dr. Spielman, thought it was really cute to call it predisposing, precipitating, perpetuating factors. I like to use normal language. It's risk factors, it's a stressor, it's maintaining factors, right? So risk factors for developing insomnia, right? A risk factor is just something that makes it more likely to happen, right? If you have high blood pressure, you're more likely to have a heart attack, but it doesn't mean you're going to have a heart attack, right? It just puts you at higher risk. And same with risk factors for insomnia. Even if you had all of the risk factors, it wouldn't be enough to give you insomnia. It just puts you at higher risk. So predisposing factors are some biological traits, some psychological traits, and some social factors. So being female puts us at higher risk, right? Having served in the military puts you at higher risk. If you have always been a thinker, if your mind has sort of always gone, right? It puts you at higher risk. If you've always been really hyperactive and really go and hard to slow down, that puts you at higher risk. If you have a family member who has had sleep problems, that puts you at higher risk, right? But again, even if you had all of these, it wouldn't be enough to actually give you insomnia. It would just put you at that higher risk. But then along comes a stressor, right? Something happens, and that can be anything. It can be a really important presentation at work, right? It can be an actual trauma that you've experienced. It can be a new medical diagnosis, right? It can be all sorts of things. And that can be enough to kick you up over that line. And maybe if you didn't have those risk factors to start with, it wouldn't have been enough to kick you up over that line, right? But combined with those risk factors, it's enough to put you up into that insomnia territory. For most people, once that stressor has resolved or has at least stabilized, sleep returns to normal, right? But for some people, during the short term, when they're first dealing with whatever that stressor is, they develop some skills that help them get through time, like help them get through and be able to get enough sleep during that time, do what they need to do to survive. But in the long run, that ends up keeping the insomnia going. Those are those maintaining factors, the kind of spending too much time in bed, napping, having certain types of thoughts about sleep, right? Lots of other things. So in CBTI, that is what we are working on, is those maintaining factors. So we like to think of cognitive behavioral therapy like building things with Legos, right? So it is not one size fits all. Different people coming to us have different portions of this that they need to work on. Not everyone needs to work on the same things. Some people come to us and they have zero negative beliefs about sleep, right? They're fine. But they have really cruddy sleep hygiene, right? That's not most people. Most people, by the time they get to us, they know about sleep hygiene. So sleep hygiene is like going to the dental hygienist, right? Or brushing your teeth daily. It's to keep your sleep in good shape. If you have a cavity, if you need a root canal, do you go to the dental hygienist? No, you see the dentist, right? You get actual treatment, right? And that's what CBTI is. That's the actual treatment. Sleep hygiene is the necessary but not enough, right? You need to do it to keep good, healthy sleep, but it's not enough to fix sleep that's broken, right? So with CBTI, we're doing stimulus control. That's what do you do in bed? Sleep and sex, and that's it, right? That's all that bed is for, and acute sickness, but in general, right? Sleep and sex, and that's it, right? Bed, sleep, bed, sleep, bed, sleep. You don't want to do other things because then your brain starts to learn, I do other things in bed. Sleep efficiency training. We decrease the amount of time that you spend in bed to the amount of time that your body is actually able to sleep. And that builds up the sleep drive, and gets you on a schedule. That's that circadian rhythm entrainment. And then we start giving you time back. Once you're able to sleep for the vast majority out of the time that we give you in bed, then we start giving you more time. It's not fun, but it works. And you get to a much better place. And then there's doing the relaxation, having time to worry, and helping you change your thoughts. So, and the order that we do this in depends on the person sitting in front of us and what they actually need. So, CBTI is good for most, but not all people, right? CBTI, we can do a type of it, but not the full thing if you have seizures or uncontrolled bipolar disorder, because we don't want to do some of the things of CBTI. It could set off seizures or a manic episode if we do it, so we don't do that part of it, right? We also, it's not going to be super helpful if you have an uncontrolled substance use disorder, right? If you are using substances a lot, then it's not going to be as helpful. If you're doing exposure therapy for PTSD, CBTI is a pretty intense treatment, so is exposure therapy. And you need to be able to concentrate on one and then the other. You can't, it's really hard to do them both at the same time. So exposure therapy is a type of therapy for PTSD where you go through what happened and process it with the therapist and kind of are able to get used to exposing yourself to what happened. So that's the super brief, not great explanation of it, but it is one of the two therapies for PTSD that work the best. So one of the two main evidence-based treatments for PTSD. It also CBTI should not be used if you don't have insomnia. That should be obvious, right? But you would be surprised how many people get sent to us because they're having trouble with sleep, but it's not actually insomnia. And so we then would not do CBTI. Working nights is less of a problem. Night shift is less of a problem because at least it's consistent, right? Rotating shift, you can't do CBTI because rotating shift is terrible for everybody, everything, right? It's just, you can't get on that steady schedule. But if you have a history of alcohol or drug problems, we can certainly work with you. That's not going to interfere. If you have other psychiatric conditions, as long as it's not to the point that you're not going to be able to do the treatment, that's kind of the line, right? If you're so depressed that you can't do the treatment, then CBTI is not going to help. But if you are depressed, but you can get yourself to do the things, then it's still going to help. Chronic pain conditions we see in combination with insomnia all the time, right? And certainly work on that. And other sleep disorders, we often see people who have sleep apnea or whatever else. It's most helpful if you're actually using your CPAP, which we'll talk about, right? So, how do you get help for insomnia if you think you have insomnia? One, the VA actually has a self-management tool online that is called the Path to Better Sleep, and that is online CBTI. You're walking yourself through CBTI, and it can be very helpful. It's, of course, if you can get in with a sleep provider, the VA, we have a sleep psychology clinic in the sleep medicine clinic. If you can get over there, that works probably the best, is seeing an actual provider. But second best would be that VA Path to Better Sleep, and then also the CBTI Coach app for your phone. You can see the picture there is the app picture. And it has lots of great information about sleep, and you can keep track of your sleep and learn about different habits and how to change them. And it works best in combination with seeing a sleep provider, but if you can't, it can also be helpful on its own. Yes.
Is the website, the Path to Better Sleep, is that pretty much the same as the app, or is it,
It's more.
Really?
It's much more in depth and walking you through, kind of going through, yeah. And it has its own kind of giving you your sleep prescription and things like that as well on it. So that's insomnia. Quick break for questions about insomnia. We covered it? All right, good. So sleep apnea. So there's different types of sleep apnea. Central sleep apnea is when your brain doesn't tell your body to breathe. Obstructive sleep apnea, which is what most veterans, most people have if they have sleep apnea, is where the airway itself closes up in your sleep. And then if your airway closes up, even if your body is trying to breathe, no air gets in, right? And then your oxygen goes down. So, if you are overly heavy, right, then sleep apnea, you might sometimes develop sleep apnea. And if you have sleep apnea that's untreated, the other way around, often you will gain weight. So you can kind of go both ways, right? Untreated sleep apnea is an independent risk factor for death. So if you have it, get it treated. And moderate to severe sleep apnea is right now 3% among women and 10% among men aged 30 to 49 years old. As women hit menopause, they start evening out with men, and women start getting closer to the same amount. Although that's a little different from this. This one's saying prevalence is 9% among women and 17% among men in 50 to 70 years old. I've seen some different numbers. So risk factors for sleep apnea. Gender, we've already said, especially in younger years, men are much more likely to have it than women. Age, as you get older, the more likely you are to get sleep apnea. Weight gain. Genetics, if you have lots of sleep apnea in your family. And then anatomy. So if you're looking at, this is a picture of people's mouths, clearly. And that class 3 and especially class 4, if that's what it looks like inside your mouth, you're a lot more likely to end up with sleep apnea. Sleep apnea is worsened by medications like benzodiazepines, and it's also worsened by alcohol. So if you're waking up and you're choking and gasping, or people are telling you that there is a train going through when you're sleeping, right? That's what it sounds like. If there is, someone tells you that your breathing has paused while you're asleep, or, like I said, the snoring, especially the loud snoring. If it's louder than talking, that's where you start. Some people just naturally kind of go, and that's usually not a problem. But and then feeling unrefreshed, right? You know you're getting enough sleep, but you're waking up and you're still feeling like you didn't get enough sleep, right? And if you're feeling really dozy during the day, you're feeling sleepy during the day, again, even though you know you got probably enough sleep, but you just can't keep yourself awake, right? And that morning sore throat and congestion, as well as morning headaches, right? A lot of time that's a sign of sleep apnea. So when we're talking about apneas, that is when you stop breathing for more than 10 seconds during sleep, despite your belly trying to breathe. And when we're talking about hypopneas, that's where there's a partial stoppage of airflow for more than 10 seconds. So it's not all the way closed. It's not all the way, like you're still breathing a little bit, but it's enough that your oxygen is going down. Okay. So when they do the testing, they're looking at your apnea-hypopnea index, which is the number of times that you have an apnea or a hypopnea each hour on average. Right. So, right, that's what I just said. So, normal sleep is anyone who has less than 5 apneas and hypopneas per hour. Mild sleep apnea is when you have between 5 and 14. Moderate is between 15 and 29 events per hour, and severe is 30 or more events per hour. So how do we diagnose it? You can have an in-lab sleep study, which we call a polysomnogram, a PSG, and they will look at EEG, EOG, MG, EKG, all the things, right? They are very detailed, and you are hooked up to lots and lots of fun little things. The second type would be a portable polysomnogram, which still has lots and lots and lots of stuff, not quite as much as in-lab. And then type 3 is the modified portable sleep apnea testing that has a minimum of 4 channels, which would be measuring your heart rate, your ECG, your oxygen, and at least 2 channels of airflow, respiratory movement. And then there's another type 4, which is just airflow and oxygen. So we tend to do more of type 1 and type 3 here. So, yeah.
Type 3, the patient does it at home?
But you would not do that if you had insomnia, because it doesn't measure your actual, right? There's no EEG, right? So if you don't have an EEG, you can't actually know if somebody's asleep or not. So, and since it measures it per hour, you might be capturing a lot of time when they're awake and not actually be getting if they're, right? And so that would have a lot of false negatives, right? And in fact, if you have a negative on the home sleep test, they'll often bring you in for an in-lab sleep test, because if there's a high suspicion, because there are a lot of false negatives with the home. There's almost no false positives. So if you have sleep apnea on a home sleep test, you can be pretty darn sure you have sleep apnea. If you don't have it, it doesn't necessarily mean you don't have it. So CPAP, lots of people have heard of that, right? It stands for continuous positive airway pressure. Means that it's constantly pushing air at you. And it opens up the airway, right? Like inflating a balloon. There's a bunch of different interfaces for the masks. There's probably at least 400 different types of masks. So whenever someone tells me, I've tried them all, no, you haven't. Right? But it can feel like that, right? Because there's the nasal pillows that just kind of go up your nose. There's the nasal that goes over your nose. There's the full face that goes over your nose and mouth. There's the full face that sits under your nose and goes over your mouth. There's the real full face that goes really over your full face. There's, right? So there's lots and lots and lots of them. This is a picture of the machine that we tend to use here at this VA. This is the ResMed, and there are different types of settings for the machines. So there's the automatic, which kind of can sense how much air you need. There's the true CPAP, the continuous positive airway pressure, that is one pressure, and that they would have determined during a split night study, where during half of the night they diagnosed you, and during the second half of the night they changed the pressures to see where your sleep apnea was best controlled, or during a full night titration study where they're just trying to see where does this control your sleep apnea the best. And there are different reasons that the physicians make those decisions as to what's going to be the best for individual veterans. There's also a totally different type of machine that looks exactly the same and functions. It's so there's you might have heard of a BiPAP or a BPAP, and that's just two different pressures. So it's a different pressure when you're breathing in from when you're breathing out, and there's different reasons that people might need that versus the CPAP or the auto CPAP, and so again, that's a decision that the physician would make to see what is going to control what you've got going on the best. There's also ASV. I mean, there's other things like ASV and yeah. But looking at outcomes with and without CPAP treatment. So this is looking at the cardiovascular events, right? So events per 100 person years. So in controls, they don't have any sleep apnea, right? And then we have snorers that don't have sleep apnea. They're just snorers, right? And then we have untreated mild to moderate sleep apnea, untreated severe sleep apnea, and sleep apnea on CPAP. So untreated severe sleep apnea, that's not great, right? Well, but on CPAP, you return back to about the same level as a snorer, right? So you're doing much, much, much better, right? Another option, some people really, really can't tolerate the CPAP. There's lots of things that we can do to help you get used to wearing a CPAP, but if you just absolutely can't, there's different types of mandibular advancement. There's this dental device that you can have, and that at night keeps your teeth like that, and you wear little rubber bands that keep the two sides together, and see, that kind of opens your mouth, your throat if you do that, right? Huh?
Put mask on.
Yeah, right. Most people are like, oh, I can just get a dental device. And then they see this and they're like, I'll try and get used to this EPAP. Right? Because really, like, that's not so comfortable. Right? And then in the morning you have to bite on a piece of plastic to kind of reset your jaw. You know?
It's a lot of work.
So it's a lot of work. Or you can just get surgery. You know, right? Which again, none of these are, the gold standard is CPAP, right? Or BPAP, or right, one of the PAP, the positive airway pressure devices. So, sleep apnea and depression have a lot of overlapping symptoms, right? So with both of them, you're gonna have that daytime sleepiness, fatigue, loss of energy, poor concentration, irritability. We call that psychomotor retardation. That's really just slowing down, right? And then also weight gain, right? So those are symptoms of both sleep apnea and depression, which is one reason that sometimes if people are suspicious of somebody having depression, they might not diagnose depression until they've had a sleep study, right? Because they might want to know, is this just how it's looking, right? But there are some things that are in depression that are not in sleep apnea, right? That constant sadness or the really not getting enjoyment out of anything. That's the anhedonia. The feeling really overly guilty or really worthless. And then weight loss usually does not happen with sleep apnea, right? So there's some ways that you can distinguish between them. But if you do have sleep apnea, treating the sleep apnea tends to also help the depression, right? So you really want to, if you do have sleep apnea, you want to get treated for it. If you do have sleep apnea, you want to do whatever you can to get used to wearing it. So sometimes it's a physical problem that makes it hard to use the CPAP. Okay, sometimes it's just you need a different mask. Sometimes you haven't learned how to adjust the humidity. Sometimes the mask itself will itch the skin and you need a mask liner, right? There's all sorts of physical things that the CPAP clinic can help you get used to using. But sometimes there are more psychological barriers, right? Sometimes there's just a fear of how you'll look, right? I hear a lot, CPAPs are not sexy. I say, because snoring really is, right? Right. But there's also just this anxiety sometimes, and that's real, right? And sometimes it's based on experiences that we've had. Sometimes you might feel like you're suffocating. You have this thing on your face, and you don't have that control. And we feel a lot less control when we're trying to sleep than when we're awake, right? You feel like we're the most vulnerable when we're asleep, right? So you don't want something on your face that makes you feel even more vulnerable, even though you know it's there to help you. Your brain, right? Your fear center in your brain can't really tell the difference, right? And it's just telling you, no, this thing's trying to kill you, right? And so we have ways that we work with that, right? And so we use CPAP desensitization, which is just helping you to slowly take steps to get used to it, right? And instead of trying to all at once use it throughout the night, because that doesn't really work very well, right? And to do it in a supported way, because it's really hard to force yourself to do things sometimes when you're feeling that anxiety. Anxiety is very aversive. We don't want that, right? But sometimes you need to work through it, and you need the help working through it in order to be able to learn to use it. So I'm going to very quickly touch on nightmares. So nightmares can be a part of PTSD, or they can be a completely separate disorder. By definition, nightmares are scary dreams that you remember. I have a lot of people come to me and say, oh, I have nightmares. And I say, oh, what are they about? I don't remember them. I just wake up feeling very panicked, and I wake up in a sweat or whatever. And that can be part of the kind of arousal that happens with sleep apnea sometimes. It can be part of just nighttime panic. That can happen. It can be, part of lots of other things. So that wouldn't be nightmares. Nightmares are if you're actually remembering them. And nightmares often make people push away sleep, right? I don't want to go to sleep because I don't want to have those nightmares, right? But our body really, really, really needs REM and N3 sleep, right? So our body is going to do whatever it can do to get that good REM sleep. REM is when the nightmares happen, right? That's your vivid dreaming sleep. So the more you push away those nightmares, the more likely it is that when you do go to sleep, you're going to have those nightmares, right? You're going to go into the REM sleep more quickly. You get what we call REM rebound, right? So it's that paradoxical effect. And so it's really hard to say, I know that you don't want to sleep because you don't want to have the nightmares, but the more you push it away, the more you push away the sleep, the more likely it is that you're going to go into that REM more quickly and that you're going to end up having more. So when you do have nightmares, nightmare disorder is kind of this repeated occurrences of the extended, extremely unpleasant, well-remembered dreams. And it's usually involving threats to survival, security, physical integrity, and it's usually during the second half of the night. Why? Because we have a lot more REM during the second half of the night, right? You know what's going on when you wake up, right? You know, oh wait, nope, I'm not in that anymore. But you're still really upset about it, right? It still doesn't feel good. And it causes a lot of distress. Some people have bad dreams, but they just call them bad dreams. And they're okay. They're like, oh, nope, I had another one of my bad dreams. And it doesn't bother them. Then it's not a nightmare disorder, right? It can't be due to other things, right? It can't be due to drugs that you're taking or medications. And other things don't adequately explain it. So you don't have nightmare disorder in addition to PTSD, right? Nightmares are often a part of PTSD. It's a symptom, right? So there is some evidence that in people with, I've seen it just with nightmares in general, but the more research is with sleep apnea and PTSD, that if you treat the sleep apnea, often the nightmares will decrease. Not disappear completely, but decrease. So there's also a treatment if you don't have sleep apnea, right? But we have a treatment that's called imagery rehearsal therapy. If you have one nightmare or multiple nightmares, but that tend to repeat themselves pretty much exactly, we can work on that. We have you kind of go through the nightmare and then changing it into a better dream. You kind of have the same part, change it, practice it. It sounds all hooey, but swear it works for a lot of for a lot of people. There's mixed evidence for its usefulness, but I've seen a lot of good results from it. So again, does not treat other PTSD symptoms, can help with nightmares. For non-repetitive nightmares or nightmares that are kind of all different, there you can talk with your psychiatrist or physician about whether a certain medication might be helpful. There are some that can help with nightmares. So, good timing. Left a couple minutes for questions. Yeah.
One or two. So, things that I've read have said that if you sleep deprived for a while and then you think you can catch up on your sleep over the weekend, it typically takes about 2 weeks to get back to a normal cycle. Is that?
So I'm not sure of the exact timing of it. What I do know is you can't really catch up on your sleep. That, there's no real making up for sleep. And so it's better to get on that steady schedule. It's better to, that morning wake up time is super important, and having that steady morning wake up time. So as much as you can, keeping that block. And if you do lose sleep, if something happens, you have a sick kid, you have something that's going on that you really need to be up later, you lost that night's sleep, and the next night will just be that your sleep drive will be that much stronger, so that by the time it's bedtime, you'll actually be able to fall asleep.
That what you spoke about is mostly in the adult population, but we know that children also know under tremendous amount of stress, the world.
Oh yeah.
And there's a lot of psychological damage that's done to all these kids from the workloads that are being dropped on them by elementary, maybe not so much, maybe getting more, but this is middle school, definitely high school. What does one look at to?
So I think it's really, kids, it's the opposite for adults. For adults, we say don't go to bed until your bedtime, right? Because you want to actually have that sleep drive high enough, you want to be sleepy enough to fall asleep. For kids, you want to be in bed by bedtime. You want to be able to be going to bed, going to sleep. And that, like you said, can be really hard when you have so much homework. You're expected to be in extracurriculars as well as doing all of the really high-level work that especially high schoolers, but also middle schoolers these days are expected to do. High schoolers, naturally, their rhythms are shifted, their biological rhythms, so they tend to be more night owls, and that's just normal. So they've done research showing that schools that start later, schools that start at 8:30, the kids do a lot better than in the schools that are starting at 7:30 or 8:39 schools. Kids do a lot better. So I am an adult sleep psychologist, not a child sleep psychologist, so I don't want to kind of pretend that I have expertise that I don't. Working as parents with the schools as much as possible and kind of educating them can be really helpful.
Yeah, so I think that's one of the big challenges, right? So for me, I have two, for those that don't know, I have 2 daughters that are in high school. I've been to the school multiple times, and the question that I always ask them is, can you show me any data, anywhere published, level 1 evidence anywhere that shows that lack of sleep and increasing homework load is anything to improve performance, and you just kind of get a deadpan stare at you, like we don't really care what you say because we're going to do it anyway. But I think a lot of the research bears out that it causes a lot of psychological problems. It's depression, it's increased anxiety, so it causes growth issues, right? And it's just getting them to buy into the child's well-being is first and foremost. There's them to be a very big disconnect between what we're trying to push and what literature actually states.
Shows. Yeah. Yeah. And it is super hard. And it's, I don't know if organizing as a group of parents, right, organizing with the Parent-Teacher Association and whatever, if you can kind of get, right, there's power in numbers sometimes, and they just might look at you like, that's one parent, right? But if you can get lots of you together, that might be helpful.
To piggyback off his question, this could be adult or for children. How about gaming? Does gaming affect your sleep cycle at all? I mean, like some people game all day.
Yeah, so I think especially if you're doing it close to bedtime, that's going to be the biggest problem. That activity, that light, that, right, all of that. And typically they aren't playing Tetris, right? It's games that are a lot more activating, right? And so you want for a few hours before bed to be more in that calm mode. And so definitely kind of trying to cut off that a few hours before bed. I don't know any research that's, I think it's more the light exposure, the physical activity, things like that it might interfere in, might cause more problems with sleep. But yeah.
Did y'all do like research like based on daylight saving time?
Oh yeah. So when we lose the hour of sleep, right, in the spring, right, there tend to be for that next entire week, there are a lot higher number of cardiovascular events, as well as a lot higher number of motor vehicle accidents. So yeah, daylight savings time stinks. Yeah.
Have you heard anything about I think it's called the C-lymphatic system, that you have to be asleep at night for this system to activate in your brain?
So is that like related to the C-reactive protein, or is it not?
It's supposed to be like, it was described to me as a sort of a cleaning system for the brain.
Oh, yeah.
And you have to actually be sleeping for it to work. And so
Yeah.
that was one thing that, they spoke to about the number of hours you sleep is important because that system will not.
Yeah. And I don't know if they've looked at differences between short sleepers, long sleepers, the average sleeper, or if they've just kind of done an average across everyone. I would be more interested to see, because I've heard that you need this 7 to 9 in order to get that, to have that drainage system happen or whatever. But I'm not sure I've seen any research looking at, well, what about in people who are naturally short sleepers or naturally long sleepers? I think that we are out of time, but if we have one last question, anybody?
Who's the best professional to diagnose sleep apnea?
A sleep medicine physician would be the best person. So if you get a referral to the sleep medicine clinic, they will get you set up. If they think that there's a high likelihood that you need a sleep study, they'll get you set up for a sleep study and follow up with you.
Right.
Thank you all.
It's really good.
Thank you so much, Dr. Too. It's awesome.